Hello, welcome to another session of Surgical Pathology Digital Slide Review and Sign Out. I'm Dr. Lewis Hassel, coming to you from somewhere near the campuses of the University of Oklahoma Health Sciences. And our program today will look at a challenge in GI pathology. The patient is a 68-year-old man who has a pancreatic mass that has previously been determined to be adenocarcinoma. On review of his radiographs, it's felt to be resectable, and so he comes to surgery. And at that time, they discover a small nodule on the surface of the liver. So before proceeding further, they send this to the laboratory for frozen section evaluation. And here is a representative section in which we see this small nodule here, slightly paler than the surrounding liver tissue, with a little bit of a complex glandular pattern and so forth. As we go to higher magnification, we can see that it's fairly contained. It doesn't seem to infiltrate into the surrounding tissue. There's a few scattered lymphocytes around the edge, and we have a little bit of angulation of these glandular contours. They sort of stream through here, and here on this frozen section evaluation, there's a little bit of hyperchromasia. However, closer indications, so no nucleoli. There's no necrosis in the lumina of the tissue here. But of course, not having his pancreatic mass right in front of us, this raises concern for whether or not this could be malignancy. So let's think for a minute about what we should be thinking about. If you think about liver lesions that may be encountered at surgery in a case like this, well, of course, metastatic carcinoma is the first thing to exclude. Hemangiomas usually are evaluated radiographically these days and don't pose much of a problem at surgery unless they're small and not particularly red. The next three lesions, bile duct adenoma, bile duct hamartoma, and von Meyenberg complex, and there's probably some overlap in these, do pose challenges for us on frozen sections and are occasionally submitted for frozen section evaluation. Hepatic adenoma, usually not a problem for frozen section unless it's being resected primarily. Other liver lesions, focal nodular hyperplasia, hepatocellular carcinoma, are usually associated with typical syndromes and not something encountered incidentally. Hepatic cysts, likewise, are usually diagnostic on pre-evaluation radiograph and do not pose much of a challenge at frozen section. Well, with the round contours and benign appearance, we felt safe thinking that this was a bile duct adenoma, and in fact, so reported to the surgeon. At permanent sections, representative area is seen here. And this may be a little bit of an overlap between a bile duct hamartoma because as we see here, we have some larger ducts at the periphery, as well as these vessels. But again, on higher magnification, the glands sort of stream together. The nuclei are quite uniform, round, and unremarkable. There's no necrosis. There's not really even bile in the ducts here, although there's a little bit of eosinophilic secretion. And we have a little bit of this peripheral lymphoid inflammation, which is actually fairly characteristic. If we look at other biliary tissue in the sample here, and I don't know if we've got it to compare, maybe we can look over here. We can see that the biliary epithelium in these benign areas looks fairly strikingly similar to what we would see in our small adenomatous lesion. So the key findings to be thinking about in this scenario are, as I've indicated as we are waiting for this to load, that bile duct adenomas have very low-grade cytology. Let's go back and we will look at this again very closely. We have low-grade cytology, round nuclei, um, fairly small, uniform, but oftentimes connected glandular structures without biliary secretion, without necrosis, or without atypia. Whereas carcinomas will usually have atypia, have probably some necrosis, have variable sized glands, and will often have a more infiltrative or irregular pattern. Additionally, a small feature of a bile duct adenoma that we did touch on is that peripheral lymphoid infiltrate. Oftentimes that's very helpful and not typically found uniformly in metastatic lesions. So there's our case for today. Final sign-out diagnosis, bile duct adenoma in a patient with pancreatic carcinoma that went on to be resected successfully. Well, thank you so much for joining us today. And we want to thank Chelsea Zhang for her contribution of this beautiful watercolor that's formed our sub-theme today. If you like this, please subscribe so you'll be sure to catch new releases and share it with friends. Also, we welcome your comments. And so if there are topics or challenges that you'd like to see discussed, maybe differentials that you'd like to see considered, please don't hesitate to drop me a line either directly at email or in a comment in the box below. And until next time, thanks so much for joining us.